Alright, so we're back. Let's talk some elbow rehab design considerations. When we're talking non-surgical management, uh, lots of times this is going to be something we're going to try, and if it works, then great. If it doesn't, then usually after we've given it a month or two, we start to look at our surgical options. Okay, so this is really an essential step to make sure we address the underlying causative factors. If all we're doing is symptom management, then clearly we're not going to make them better. Lots of variability here, so it depends on their age, what position, what sport they play, and for some patients, non-surgical may not even be a real uh, viable option for them. So we may go straight to our more aggressive uh, alternatives. Okay. So generally speaking, we'll break this out. Our 2 months, we'll start with this immediate motion phase. It's going to last about a week. So we've talked about police before, that optimal loading. We want to improve pain-free range, retard the onset of soft tissue losses, muscle losses, minimize their pain and inflammation. So our modalities will be helpful here, but that's not all we do. We'll be doing gentle joint mobilizations, maybe some elbow distraction, submaximal isometrics, gentle active and passive range of motion at the wrist, at the elbow, and at the shoulder. So the idea here is not rest, not at all. It is getting them moving submaximally and hopefully trying to trigger the healing response. So some examples of some things that we might do in this immediate motion phase would be using things like Theraputty. We'll have this in lab. Flexor and extensor stretches, just passive stretches. Wrist curls, wrist extensions using dumbbells. We can use various tools, sledgehammers, pronation, supination as well. Um, these are called power webs. We can use this for flexion or for extension, just having them go through some standardized resistance training. Okay. After we've initiated this immediate motion phase, we go into our intermediate phase. This is usually going to last the duration of weeks 2 through 4, so this will take us through the end of the first month. Lots of times extension is going to be particularly painful, and a lot of times patients with early elbow pain will notice pain in extension first. We know that the anterior fibers of the ulnar collateral ligament actually provide restraint in extension. So if we've got some early ulnar collateral ligament involvement, then they don't like that lockout position. And a lot of our strength and conditioning exercises may force them into that position. So we have to be cautious here as well with what they're doing in the weight room. So something as simple as a bench press to full lockout is going to be contraindicated. But some of our other movements might be, we don't think about something like a trap bar deadlift as being elbow involved because our elbow doesn't move, but it's a loaded extension. Okay, so we have to be cautious with what we do. So whether it's free weights in the hands or more targeted upper body exercises, we have to be cautious here. So our exercises here involve isotonics, tubing exercises for the shoulder. We will have done rhythmic stability early on in phase 1, and then we can use some scripted programming like the Throwers 10, light plyos, swinging and hitting drills if they're baseball, softball players. May be beneficial here. So some examples: active range of motion with overpressure and extension, simple isolative strength, biceps curl, triceps extensions, and we're going to progress resistance and load and volume. Now, remember back from our correctives lessons. So inhibition here might involve foam rolling the lats, might also involve some trigger point massage to the upper trap. Lengthening would probably involve pec minor, pec major. We may also do some lengthening work to the posterior capsule. Okay. From there we go to strengthening. So here's where our biceps curl and triceps extensions come in. And then we go into integration. Okay, so as we said before, keep in mind this is not how we do strength and conditioning. This is a difference. Okay, we do our isolative strengthening type exercise at the very end if they're healthy. If we're talking about rehab, then we usually flip that around and we want to restore motion first and have them move through it in an integrated fashion at the very end. Okay, so using this example, our intermediate phase, week 3, we go to eccentric dominant biceps and triceps. So remember that 4 to 2 relationship where maybe a 4 count down and a 2 count up. Okay. Some global shoulder work, internal external rotation, scapulothoracic stability. Some of our plank holds might be beneficial here, but again, be cautious with what we're doing to the elbow. Okay. Advanced strengthening comes phase 3. What I've showed you here, Tebow was commonly criticized, among other things, from his sidearm delivery. And that may come from the fact that before he played football, he was a baseball player. And you'll see this quite often. Patrick Mahomes does the same thing oftentimes. And he won't use the same arm delivery slot with every throw. He alters it depending on what's in front of him or where he wants to deliver the ball. Okay, so we notice as we get lower in that arm slot, it alters the forces at the elbow pretty substantially. If we're more over the top, next to no load, valgus load at the elbow. As we get more sidearm and submarine delivery, then that load increases pretty substantially. Okay, so during this phase, we want to address any biomechanical issues. There's a question mark here for isokinetic assessment. Very rarely anymore would that be an issue, especially on an upper extremity injury like this. But certainly we want to do some functional testing and see how they do. Some examples here of advanced strengthening. Strength and endurance exercises, continue that thrower's 10, progress their plyos, maybe with some weighted balls, progress swinging and hitting. We would introduce that interval sport program at about week 6 and then put them on a maintenance program. By now, we should have a pretty good idea whether this is working or not, quite honestly, by phase 3. So phase 4, we're either going to return them to activity or they're probably going to head toward surgical intervention. Okay, so week 6 to 9 would be, remember this is still conservative, continue that thrower's 10, continue functional drills to unrestricted activity. If successful, then we've averted surgery and all is well, and we'll keep them on a maintenance program. If not, then we're looking at, if it's UCL injury, then we're talking about the type of rehab we've already discussed with respect to Tommy John. All right, some common conditions we deal with at the elbow. Epicondylitis, see this pretty frequently, especially tennis and racket sports. Active rest is going to be critical. Our cross-fiber massage, instrument-assisted soft tissue mobilization is going to be very helpful here. Address mechanics. Lots of times this may have to do with the racket. So a lot of times a beginner at racket sports will choose a really large racket. It's more forgiving. They don't have to strike the ball so perfectly. And what that does is that increases the lever arm. So while it's easier for them to play, it increases their risk for elbow and shoulder issues. So we want to make sure they are not putting English on the ball. In other words, flexing. We want them to keep a relatively stiff wrist as they drive through. Flexibility exercises here. Stretching is beneficial. Question mark there for counterforce brace. It's like a Chopat strap for your elbow. It is effective for symptom management, but it's not addressing the underlying cause. Okay. In cases where we've got an ulnar neuropathy, it's rare that this is going to happen all by itself. There's usually other pathologies in play. They'll be tender over that cubital tunnel and they'll start to lose grip strength. The motor compromise is usually, pain is one thing, but starting to lose grip strength is quite another. Lots of times we'll see this in connection with carpal tunnel syndrome, and so I've seen that at the industrial setting probably more so than anywhere else, where it's not uncommon for a patient to have both carpal tunnel and cubital tunnel concurrently. Okay, so we have to eliminate whatever's causing it. Usually it's excessive gripping, lots of digital pinch, that kind of thing. If the patient has this condition, then usually the easiest fix for this is that ulnar nerve transposition. Okay, these are usually slow progressing. We have to be real cautious here in when we can return them to work or return them to play. And even, oftentimes they may have had these symptoms for weeks, or, well, oftentimes they've had it for months or even years. And so just moving the nerve doesn't necessarily cure it. So we have to instruct our patient that even following surgery, it may still be some time before they get a return there. Okay, neuroflossing can be beneficial there. I think you guys went through some of the neuroflossing techniques before, but just keep in mind that from root to distalmost aspect, most nervous tissue can move upwards of 2 or 3 millimeters. So it's not a stationary structure. It doesn't like to be stretched by any means, but it should be mobile. Okay, UCL injury or reconstruction. This is not a performance enhancing surgery. In some circles, pitchers will talk and, oh, so-and-so had Tommy John and he's 3 miles an hour faster than he was before the surgery. This is not something that we undergo lightly. You can dispel that myth among your athletes. No surgeon in their right mind would do it for an athlete who isn't injured, but lots of times you'll hear dugout talk where they seem to think that having surgery could be their ticket to the big leagues. It's not that way at all. Non-operative approach, we've said, this may be upwards of 2 months, 6 weeks, even 2 months of non-operative conservative care. We really don't want to have to undergo this if we don't have to, for our patient's sake at least. If they've had the reconstruction, then, like we said, 26 weeks before they're throwing again competitively, and they're not even going to begin until 14, 15 weeks. Alright, so I'm going to pause the video here, and we'll shift gears over into wrist and hand for the next lesson.